All right. Good afternoon, Patrick, and the rest of our residents who are yet to join. Today, we want to talk about cataract. It's a very important topic because cataract is a leading cause of blindness worldwide and is the second leading cause of visual impairment. By this time, I hope those terms are very clear. We should know what blindness is. According to the World Health Organization, blindness is visual acuity of worse than 3/60 in the better eye. And 3/60, like I said the other time, is equivalent to counting fingers at 3 meters, or visual field of less than 10 degrees in the better eye. That's how the World Health Organization defines blindness. But visual impairment refers to visual acuity worse than 6/18. So we have, worse than 6/12. So we have mild from 6/12 to 6/18. Then we have moderate 6/18 to 6/60. Then we have severe visual impairment 6/60 to 3/60, or counting fingers at 3 meters. All right, so this will be the outline of our presentation. Hello, Patrick. Are you online? Hello.
Yeah, Dr. Oteng.
All right, good. So I'll give some introduction. Then we talk about the epidemiology and causes of cataract, the types of cataract, the clinical features. Then we look at treatment and complications. It's going to be quite brief. So the word cataract comes from a Greek word which means waterfall. It's all because when someone has cataract, the appearance is just like what you see when you look at a waterfall. This whitish appearance, like the way the person sees. It's as if the person is looking through a waterfall. So that's the meaning of cataract. The worldwide, in Ghana, the last blindness and visual impairment survey we did, we realized that about 0.74 of the Ghanaian population are blind. And of this number, about 54.5% is due to cataracts. I'm sure the situation may not be very different from Liberia. I looked at some figures, and the prevalence of blindness in Liberia is about 1%. What's the current population of Liberia? It's about 350,000, sorry, 3.5 million, or it's more. Patrick? All right, Patrick cannot hear me. So the burden of cataract is not born equally. Okay, the burden is found to be higher in areas of low socioeconomic status. So even within a country, you find out that the rural population has more prevalence of cataracts than the urban population, and the reasons are due to a lot of factors which will come out in the course of this lecture. People who have cataracts, knowledge, or most of them may not be aware that there is help that can be offered, and even those who are aware, the services of an ophthalmologist who can treat their cataracts may not be easily accessible. So all those are factors: poverty, poor nutrition, all those are contributing factors to the higher burden of cataracts in areas of lower socioeconomic status. Okay, so people who are not seeing well, usually they are more likely to fall. They have depression, and most of them may report social isolation. In fact, Visual impairment just comes behind arthritis and heart disease as the common cause of chronic impaired function in the older folks, those who are more than 70 years. Okay, and it's been found, it's been known that with adequate treatment and visual rehabilitation, people who were hitherto dependent now become independent. They're able to do their jobs and they rely less on social services and institutions. This is in areas where such social support services even exist. Okay, so in our environment, when someone is blind, that person will depend on someone to even help the person to go to the washroom. Children are made to sit at home instead of being in school to take care of the blind, okay? So if we are able to solve this problem, the repercussions are quite great on the general economy as well as education of our children, okay? So visual impairment is quite common. The leading cause of visual impairment is presbyopia. I think I mentioned it the other time, followed by unaddressed refractive error. I said presbyopia is not technically considered as refractive error because we define refractive error as the eye not being able to focus a sharp image on the retina when the eye is relaxed. So the eye looking at something which is far away at a distance of at least 6 meters. Okay, cataract comes after unaddressed refractive error, and the burden of cataract is about 65.2 million worldwide, followed by glaucoma 6.9, corneal opacities, diabetic retinopathies, and then trachoma. Trachoma is fortunately going down in most areas in Africa because of the trachoma control programs that have been instituted, but it's still a problem in some rural areas in Ghana. Okay, so as I said, the greater burden is found in the low and socioeconomic countries, and even in these low and middle income socioeconomic, middle income countries, the distribution is not even. You have more people with cataracts in the rural areas than in the urban areas because of the reasons I've listed already. In such underserved populations, you find that women tend to be more, and there are lots of reasons. Women, especially in most parts of Africa, may not be empowered to take the decision to want to travel to go to a place to have a cataract surgery when they have all these children to take care of. Migrants in certain countries may not be economically empowered to be able to make the decision to want to have their cataract treated, okay, because of cost, accessibility, and all those issues. People with certain kinds of disability may be disadvantaged when it comes to access to cataract surgical services, okay? Yeah. So, like what I found, in Liberia, the estimated prevalence of blindness is about 1%, okay?
Okay.
And of this, that is if the Liberian population is about 3.5 million. Correct me if I'm wrong. What's the average Liberian population?
An average.
Yeah, the current population.
Yeah, that should be some between 20 to 35. That is, we have more of the youthful, more of the youth age population.
Okay, so 20 to 35 million.
Yeah. Oh.
Or you mean 2 to 3.5 million?
No, I'm looking at the age. I thought you said average age.
No, like I mean the population.
It should be about between 3.5 to 3.8 million.
Yeah. So if you take it to be 3.5 million, then from that estimate of 1% of the population being blind, it means we have 35,000 people who are blind in Liberia. And of this, half of them, 17,500, are due to cataracts. And blindness from cataract is curable, it's treatable, and it is reversible. Unlike blindness from glaucoma that we will be talking about in our next topic. Okay. So all these people are blind needlessly. They can be cured, they can be treated, and their vision can be restored. That's if their blindness is purely due to cataract. Okay. As we grow, lots of changes occur within the sorry, within the crystalline lens. There is increase in the hardness of the lens, and there is loss of accommodation. I said the other time that presbyopia is as a result of the lens not being able to change its shape to assume a more spherical shape to help focus on near objects. Okay, that is what leads to presbyopia, and it comes with aging. Most people around the age of 40 will have symptoms of presbyopia. Okay, and it's all because of the changes that are occurring inside the lens. The lens also increase in density. This has an effect on the refractive state or the refractive function of the lens as well. With age, the lens increases in size as well as in its opacity. That is the cataract. So the lens, which is very, very transparent right from the beginning, with time becomes quite opaque. What are the risk factors for developing cataract? The most important and significant risk factor for cataract development is age. Okay, it's been known that for most people more than 65 years, they will have some cataract, but it's not all the cataracts that will be visually significant. If you examine all people who are around 60 to 65, you will see that most of them have cataracts, but they may not present with symptoms because it depends on how dense the cataract is. But as they grow, assuming all of us are going to live up to 100 years, more than 95% of us are going to develop cataract. Okay, some of which may require intervention. Okay, so it's not all cataracts that require intervention. As the lecture goes on, you will know some of them do not require, surgical treatment. If it's very mild and the opacity is not so much, refractive correction may suffice. Okay. So the second risk factor is people who live in the tropical countries or who live in poor countries. So countries where there is low socio-economic status, they tend to be at more risk of developing cataracts. This is because in most of these countries, during childhood, the children will develop certain diarrheal disease that can make them severely dehydrated right in early life. And this has been shown to predispose to the development of cataracts in future. Okay. And then in tropical countries, because of the effects of the sun, radiations from the sun, they also tend to promote the development of cataracts. Our diets that are less rich in antioxidants are found to be a risk factor for the development of cataract, as well as heat. The heat in the tropical environment predisposed to cataracts. Okay. Cataracts usually, apart from the risk factors that I have talked about, some cataracts may be associated with diseases of the eye. For example, if there is inflammation of the eye, uveitis, it can, as a complication, lead to the development of cataracts. So the uveitis itself can lead to a secondary cataract, as well as the medications used in treating the uveitis, the steroids. The topical steroids used in treating uveitis can also predispose to the development of cataracts. People who have glaucoma are also at risk of developing cataract, especially those who are on eye drops like pilocarpine. It's been known to be associated with the development of cataract. People who have glaucoma who require surgery, like trabeculectomy, are also at risk of developing cataract because of the surgical trauma. Any form of trauma, blunt or penetrating injury to the eye, can predispose to the development of cataract. Now, post-traumatic cataract can develop either immediately for penetrating ocular injuries, or for blunt injuries, it may take some few weeks or months, or sometimes even years for the cataract to develop. Okay, so this slide shows some of the systemic diseases or risk factors that can lead to cataract. Obviously, the number one we know are the endocrine factors like diabetes. Okay, diabetes is known to be a very common systemic disease associated with cataract. So usually, cataracts develops with age. As you grow, the natural lens assumes, or the natural lens naturally becomes opaque. But this one should develop usually around the age of around 60 years and above. But when you have someone who is 40 years coming to you and the person has cataract, you have to rule out diabetes, okay, or rule out other systemic endocrine conditions that could have predisposed to the development of cataract at such an early age. So diabetes, hypothyroidism, and then certain rare endocrine conditions like galactosemia. So this one is an inborn metabolic error, okay, where there is a lack of some enzymes required in the metabolism of glucose, okay. So children may be born with cataract, and especially if the cataract is bilateral, you have to rule out some of these conditions: galactosemia, hypocalcemia, and then hyperthyroidism. They all predispose to development of cataract. Genetic conditions like Wilson's disease and then myotonic dystrophy are also associated with cataract. And then medications that are used in treating certain systemic diseases like steroids, okay, whether it's ocular or systemic use, have been associated with the development of cataract. Intake of alcohol can predispose to the development of a particular kind of cataract called the subcapsular cataract. I will show when you get to the types, you get to know how that type looks like. Medications like pilocarpine used in treating glaucoma, I've mentioned it already. And then the phenothiazines, okay, used in the psychiatric units have also been associated with the development of cataract. Certain viral infections, congenital viral infections like rubella and chickenpox can result in the development of congenital cataract. Syphilis, toxoplasmosis can all result or predispose to the development of cataract in children. This one is different from the senile cataract that's, yes, that we know of. Atopic dermatitis also predisposed to development of cataracts. Yeah. No. No. All right, sorry. And then chromosomal abnormalities like Down syndrome, Turner syndrome have all been associated with cataract. Okay. I included Marfan syndrome, homocystinuria, and then Ehlers-Danlos. Those may not necessarily be cataracts, but those predisposed to dislocation and subluxation of the lens. But those dislocated or subluxated lenses can also become characters, okay? They can also become opaque. So let's quickly remind ourselves the anatomy of the crystalline lens, okay? All right, so the lens has a nucleus and a cortex, and then the cortex is surrounded by a capsule. Okay, so we have an anterior capsule of the lens, and then we have a posterior capsule. So there is the anterior capsule, then there is the posterior capsule, and here we have the cortex. At the center, we have the nucleus. The nucleus, we have the nucleus consisting of the fetal nucleus, which is the very first, sorry, the embryonic nucleus, which is the very first to be formed. Yes, please come in. Then we have the fetal nucleus, next to be formed. Then we have the infantile nucleus. Then we have the adult nucleus. Usually, the nucleus, the lens is like onion. when you cut a piece of onion, there are many layers. The innermost part is the first one that is formed. The body does not shed that away. All those fibers will continue to be there, and the new ones will be growing around it. So the hardest part of a lens is the most central part. Okay, the most central part, that's the hardest part. It's not like the skin where whilst you are growing, but some cells are shed away. Please give me some few seconds. Patrick, give me just a few seconds.
No.
Yeah. Okay. All right. Let me give you a number. Call him and then let him. So search for Patrick. Canada. Sorry. Let's continue. Yeah. So that is how the normal eye looks like. Okay. We should be familiar with how a normal eye looks like. So with this section of the eye, we have the crystalline lens here, right behind the iris, okay, within the pupillary axis. And the lens is held in place by zonules that arise from the ciliary body. All right. Now, this is an eye that has developed cataract. So you see that right in the pupillary space, there is this whitish opacification. The picture on the right, this eye has been dilated. The pupils have been dilated. That's why you see the cataract as big. But the cataract is in both eyes, but it appears to be denser in the right than in the left. Okay, so please call for VSD. All right. So the lens is usually transparent because one of the main functions of the lens is refraction. And if the lens is not transparent, light cannot pass through for the lens to focus the light rays coming into the eye onto the retina. And the lens is transparent because of how intricately the fibers have been arranged. Okay, the biochemistry of the lens cells and fibers are very, very strict. So the slightest insult to the lens will result in opacification. So the covering of the lens, the capsule, contains cells that produce lots of ATPs that are very, very useful in helping to maintain the right electrolytes environment inside the lens. If there's any imbalance in the electrolytes inside the lens, then it can lead to the coagulation or denaturation of the proteins inside the lens. The proteins can aggregate, and that is what leads to the cataract. Okay.
Okay.
So cataract is simply when the lens becomes opaque. So this is another picture showing a section of the lens. So that's the nucleus. Okay. Then we have the outer cortex here. The covering is the capsule. The whole of it is held within the pupillary space by the zonules. Okay, the lens doesn't have any vessel; it is avascular, so it is nourished by diffusion of nutrients. Okay, from the aqueous to the cells. Okay, most of the metabolically active parts of the lens are on the outer surfaces. As I said, the inner parts are the very, very old cells. So there need not to be any diffusion of these nutrients to the core because there is no metabolic activity occurring there. All right. So the incidence of cataracts, as I said, lens opacities is normal with aging, but the more you grow, the more the likelihood of opacification of the lens. So it's been estimated that for people who are between 50 to 60 years, about 65% of them will have opacity of the lens. For people who are more than 80 years, nearly 100%, all of them will have some level of opacity of the lens. So that means if all of us should live up to 80 years or more, you have cataracts. Okay, but whether we will be symptomatic or not depends on the density of the opacification. Okay, so these are some of the causes of cataracts. In congenital cataracts, they could be due to genetics, so familial or hereditary reasons, infections that occur to the fetus, intrauterine infections like rubella, toxoplasmosis can predispose to the development of congenital cataracts. Maternal drug injections can also result in the development of some cataracts. So most commonly, like I've said already, it is aging. Okay, so the elderly, just by mere fact that you are growing, can predispose you to cataracts. And then I've mentioned this already: diabetes, Wilson disease, hypocalcemia, galactosemia are all secondary endocrine causes of cataracts. Drug-induced steroids, miotics like pilocarpine, amiodarone, and then phenothiazines, they can all cause cataracts. Trauma, okay, and then inflammatory diseases of the eye like uveitis can cause cataracts. All right, how do we classify cataracts? We can classify cataracts based on their morphology, okay? So morphologically, we can classify a cataract as being a subcapsular cataract. I showed you where the capsule is. The capsule is a membrane that surrounds the whole lens, okay? So within the capsule, we have the cortex, okay? So if you have the cataract just localized beneath the capsule, we call it a subcapsular cataract. And we can have an anterior or posterior subcapsular cataract. Then we have nuclear cataracts, okay? This one involves the central part of the lens. Then we have cortical cataracts. So the cortex, good. So there's the lens, that's the capsule. So any cataract that develops right beneath here is called a subcapsular cataract. So this is a posterior subcapsular cataract. It's an if there's any opacity here, we call it an anterior capsular cataract. Okay, if it's located right at the pole, then we call it a polar cataract. So the lens has a pole. This is the equator of the lens. Then this is the anterior pole of the lens. That's a posterior pole. Okay, so if the opacity is mainly around the nucleus, like this, then we say it's a cortical cataract. Sometimes you may not have just a particular type. You may have a mixture. The opacity may involve the various layers. Okay, but if one layer is more involved, then you can say this is a nuclear cataract, this is a cortical cataract, it's a subcapsular cataract. Okay, cataracts can also be classified based on the level or the degree of maturity. So we can say a cataract is mature when the lens is completely opaque, or immature when, yes, there is opacity, but light can still pass through. You can still see through the cataract to see the fundus. That's an immature cataract. And then beyond a mature cataract is what we call a hypermature cataract, or some call it intumescent cataract. So here the cataract or the lens swells, and then when it shrinks a bit, because the capsule was stretched, okay, the surrounding capsule appeared to be shrunken, and the integrity of the capsule is compromised. So it allows some content of the lens to leak into the aqueous or into the surrounding areas of the eye. And this can incite inflammation, okay? If you have heard of phacolytic glaucoma, it's as a result of these hypermature cataracts. So when you have cataract that is there, that's hypermature, it can lead to a form of uveitis and then a secondary form of glaucoma. Now, next on the spectrum is what we call the Morgabinian cataract. When a hypermature cataract progresses, there is liquefaction of some parts of the cortex and allows the very hard nucleus to sink inferiorly. I'll show a picture shortly. Okay, so how do you differentiate between a mature and an immature cataract? So obviously, the visual acuity will be worse in a mature cataract. usually from hand movement to perception of light, as compared to an immature cataract. That is maybe about 6/60 or counting fingers. And then like it's partially opaque in immature cataract, but it's totally opaque in a mature cataract. Okay. There is a shadow of the iris. This is when you do the red reflex. And then you can see the fundus in an eye with an immature cataract, but hardly can you see the fundus in an eye with a mature cataract. So this eye has cataract, but you can see that the central brownish hard nucleus that should have been somewhere here appears to be sunken. It's all because the surrounding whitish cortical matter has liquefied and allowed the nucleus to sink. So that kind of cataract, we call it a Morgagnian cataract. Okay. Yeah, that is a cataract which is very, very old. So the lens is transparent, as I said, because of how well arranged the crystalline fibers are. Okay, if there is any insult or there is any damage, whether from trauma or from radiation or from any other chemicals, that will disrupt the cells that are responsible for ensuring that there is the right fluid and electrolyte balance inside the lens. If any of them is destroyed, then it can lead to disorganization of this arrangement. And that's how cataract develops. So the pathophysiology, not very well understood, but these pathways have been elicited: glycolysis, pentose phosphate pathway, and then the polyol routes. This has to do with metabolism of glucose, okay? Because as I said, the water and electrolyte balance inside the lens must be kept very tightly. You require cells to produce a lot of ATP because this is an active process. If there's a problem in these processes, glycolysis, pentose phosphate pathway that produce ATP are affected in one way or the other, then it's going to affect the function of the epithelial cells in maintaining the integrity of how well arranged these fibers are. And that can lead to precipitation of the proteins inside the lens and can lead to cataract. Okay, so people with cataract will usually present with a decrease in their visual acuity that is gradual, not associated with any pain, and the decreased visual acuity sometimes worsens in bright light. For example, when they are driving at night, they will experience glare, okay? Some of them may also complain of double vision, but the double vision in the case of cataract is monocular diplopia. That means it is double vision that persists even after closing one eye. If it is a binocular diplopia, when you close one eye, the double vision disappears. But when you close one eye and you still see double vision, that is monocular diplopia. It can happen in people who have cataracts or people who have dry eye syndrome or people who have astigmatism, okay? Monocular diplopia is usually caused by a problem inside the eye itself, but binocular diplopia may be as a result of the nerves that supply the extraocular muscle. That one is more serious than monocular diplopia. Some cataracts, especially the nuclear cataracts, can result in the development of a myopic shift. When the nucleus is so dense, okay, then the refractive index of the central part of the lens becomes very high. This results in an overall increase in the refractive index of the lens, okay? And images that are formed from distant objects will now be formed in front of the retina, okay? That is a myopic shift, okay? Some will also have observed, or they may have been told, that the central part of the eye appears whitish, what we call the white reflex, okay? So in evaluating such a patient, The past medical history may reveal incidences of trauma or infection intrauterine, or the presence of endocrine conditions like diabetes, hypothyroidism, and so on and so forth. Okay. Family history of cataracts. In some variants, where there are hereditary risk factors. For example, in some of the congenital cataracts, they may be hereditary. So you may have a family where all the children have cataracts. In that case, the parents need to be made aware so that the moment a child is born, the child will be examined and the cataract develops is taken out as early as possible so that the child does not develop amblyopia. Okay. On examination, you may observe that the vision is decreased for both distance and near. Okay. However, the vision may be very good for near if the cataract is the nuclear type of cataract. If it's nuclear cataract, they become myopic. They get what you call second sight. Usually when you are 40 years going, you become presbyopic. Okay, that means you have difficulty reading. But when people are growing and then they develop nuclear cataract, all of a sudden they are able to realize that they can now see clearly at near, okay, because of the myopic shift that they have. But their distant vision remains blurred. Okay, you may find that the lens appears opaque. You can use torchlight to be able to examine this, or with your ophthalmoscope. Because the lens is opaque, your red reflex is going to be absent or dull. Okay, yeah. And then you also have to check the pupils. As I said the other time, if there is a disease with the optic nerve, you may have what you call the relative afferent pupillary defects. Okay, in this case, even when the cataract is taken out, visual prognosis will not be very good because you need an intact optic nerve for you to be able to see. So what we are seeing now, this first picture shows a normal eye with a clear lens. Images are well focused on the retina. But in an eye with cataracts, because of the opacities inside the lens, there is scattering of light. That is what results in the blurred vision and sometimes the glare that the patients experience. Okay, so a normal eye driving at night, and compare it to how someone with cataracts sees when he's driving at night. So lots of glares. Okay, I brought these pictures. So normal vision is looking. Sorry, Patrick, just a few seconds. Hello. Yeah. Good afternoon. Yeah, very well. Yeah. 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 With the frame absent. Yeah. So, yeah. Yes. Yeah. Yeah. That's it. So as I said, we shall pay for the cost of the additional frame. She doesn't have it here, but it was black. I've sent you the code for that. All right. Okay. So I'll let the patient bring it tomorrow. I'll call her to bring it tomorrow. Yeah. Yeah. All right. I'm in the midst of a meeting right now, so yeah. So I'll call her to take a picture and send. Thank you. All right. Bye. Sorry, Patrick.
Yeah.
Yeah. Sorry. Yeah. So how do we manage, or how do we treat cataracts? Mainly, cataracts that are visually significant are treated with surgery. You have to take out the lens, okay, the opaque lens, and in this place, put an intraocular lens. The main function of the lens is to focus light. It's refraction, okay? So when the lens becomes opaque, it's not able to perform that function. However, depending on the level of opacity, some cataracts or visual impairment due to cataracts can be corrected with spectacles. For example, if it is, I said some of them may be corrected with glasses, spectacles. For example, if it's a nuclear sclerotic or nuclear cataract, that has given the person some myopia or has resulted in a myopic shift. Correcting that refractive error may help to improve the distant visual acuity, but it's just a matter of time. Giving of glasses to people who have cataract is just a temporary measure. Eventually, as the patient ages, the cataract is going to get worse, and the time comes when the the glasses are no longer useful. Another measure we can use to help those with cataract is improve the lightening condition. Okay, so the more intense the light around, the better the patient sees. Ultimately, we have to do surgery, and I think you should be aware that we have. You should be aware of the surgical modalities for treating cataracts. The gold standard now is what we call the phacoemulsification. Okay, but what is most commonly done is the ECCE. ECCE stands for extracapsular cataract extraction. At first, we used to perform what we call intracapsular cataract extraction. I'll explain briefly what these procedures, what actually goes into these procedures shortly. For the yeah. So when do we have to do cataract surgery? I'll go to the indications shortly, but briefly, the reasons why a cataract will need treatment. It's not all cataracts that require treatment. So a cataract will need treatment when the cataract is visually impairing. Okay, so you want to treat to improve vision, or you want to increase the independence or the mobility of the patient, or sometimes relieve fear from going blind. Okay, so these are the indications why a cataract may need to be extracted surgically. So if the visual impairment is affecting the person's lifestyle because of the cataract, it needs to be taken out. If the patient is experiencing loss of glares, that may affect driving, it may need to be taken out. Some people may have to pass a vision test, like at the Drivers and License Authority. If because of a cataract, the patient is not meeting. Patrick, I can see you are a bit tired.
No.
You've had a very long day.
No, I'm okay. I'm all right.
All right. So we'll be done soon, so that you can have some time to rest. Yeah. If the patient is experiencing very uncomfortable diplopia, monocular diplopia, it's another reason why that cataract needs to be taken out. Okay. And then if the patient notices that the difference in vision between the two eyes is so big, it can affect the brain's ability to be able to fuse images coming from the two eyes. It can lead to what you call confusion. It's also an indication for cataract surgery. Okay, and then sometimes the patient, for example, if you have a diabetic who has diabetic retinopathy, or someone with macular degeneration, which are all diseases that will come with aging, and then the presence of the cataract does not allow proper visualization of the fundus. You may want to take out the cataract so that those other diseases behind or at the back of the eye can be managed and treated well. Because with the presence of a cataract, you may not be able to even do laser photocoagulation for someone with diabetic, and loss of vision from diabetic retinopathy is irreversible, unlike cataract that can always be reversed. So sometimes it's not that the patient is not seeing well, but you want to take it out so that you can manage other diseases at the fundus of the eye. Okay. So basically, cataract surgery is quite a short procedure. What is most commonly done is a modified form of the ECC, or the extracapsular cataract extraction. We call it small incision cataract surgery 6. Okay, So we do most of our cases under local anesthesia, and injection is given behind the eyeball. We call it retrobulbar block. Okay, so that the 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 nerve fibers that will give pain are blocked, and the patient will not be moving the eyes to and fro whilst surgery is going on. So after the block, the whole surgery can, in a very experienced hand, can take about just about 20 minutes. Okay, yeah, and a small incision is made close to the cornea, and then instruments are put inside the eye to remove the cataract. So with the extracapsular cataract, we make an incision. We try to remove the anterior part of the capsule so that we can remove the cortex, the cortical matter, which is opaque, as well as the nucleus. We first take out the nucleus and then wash out the cortex. So that means you have the posterior capsule remaining, okay? And this one can serve as a bag where we can put in our intraocular lens. So if you look at the pictures, this is an intraocular lens after we have washed out the cortical matter and removed the nucleus. So we insert this intraocular lens. That should be of the appropriate power. We do some measurements before the surgery to know the appropriate power to put inside the lens. Most of the time, we don't suture. The wound that is made is self-sealing. So someone may have had a cataract surgery, but you will not see any suture on the globe itself. It's a sutureless surgery, okay? Afterwards, the eye is patched, and then the following day, we remove the patch, and voila, the patient is seeing well again. So the procedure takes about 20 to 30 minutes in experienced hands, and the outcome is quite good if there are no other associated complications. Okay. All right. So as I said, the ICC used to be the old way of performing cataract surgery. In this one, the whole lens together with this capsule is taken out, and usually it was associated with lots of complications. It's a procedure which is now abandoned. It's only done in some few instances where maybe the lens is already subluxated or dislocated. That's when people do ICC. But ECC, that we have a small, like a modified form, a small incisional cataract surgery 6 is what is most commonly done in most parts of the world, like in developing countries. We may not have all the sophisticated instruments for phacoemulsification, which is considered the gold standard. That one actually uses it uses some machine with an ultrasound probe. A very small incision is made into the eye, and the ultrasound energy is used to break the lens nucleus into pieces, and then it is sucked out. And just like we did for the ECC, an intraocular lens is also put inside the bag, inside the capsular bag of the eye, and the patient sees very well afterwards. So cataract is very treatable. These are some of the complications associated with surgery. There can be infection, what we call endophthalmitis, one of the feared complications of any ophthalmologist after cataract surgery. There can be accumulation of fluid in the macular area, what we call macular edema, cystoid macular edema. But all these can be treated. This usually happens when the procedure becomes quite complicated, okay? You want to put the lens on a bag, but in the process of operating, when that bag breaks, the vitreous comes into the front part of the eye and can result in some of these complications. Okay, if the surgery is very traumatic and very complicated, the cornea can become edematous. Okay, so difference between what we're doing initially, the ICC, that's the intracapsular cataract extraction, and what we do currently, ECC, extracapsular cataract extraction. The incision is smaller, in ECC compared to ICC. And then no sutures are required for ECC, whereas the wound needs to be stitched, okay, for ICC, okay. In ECC, we put an intraocular lens implant. At the eye, no intraocular lens is put inside the eye for ICC. Usually, you want to correct the refractive error left with glasses or with contact lens for the ICC, okay. Less complications with ECC compared to ICC. Okay, I mentioned the fecal emulsification. Let me briefly talk about it. That's the gold standard, okay? But this one requires lots of sophisticated machines, but visual rehabilitation is faster, the wound is smaller, and the outcome compared to the ECC eventually may not be that different, okay? But you require a lot of sophisticated equipment in doing this, okay? Cataract surgery can be very fulfilling. Lots of people can be operated at a time in eye camps, okay? Outreaches are done, and the following day, people who are operated all see so well, and they are empowered again. People who were then dependent are now very independent because they can see, they can do things by themselves, okay? All right, so that's the end. Is there any question? Some of the, especially with the treatment, I know may be a bit abstract to you, but it was just to give you an idea. When you are referring a patient for cataract surgery, what the patient will go through. So we don't do our cases under general anesthesia, except in some peculiar cases where it's a child or the patient cannot withstand, okay, local anesthesia, okay. Yeah, very short procedure, about 30 minutes, a day case. The patient goes home after the surgery. The following day, the patch is removed. Okay, cataract is very common. It's quite easy to identify cataract, and when it's visually significant, you have to refer to an ophthalmologist, okay, for treatment. Thank you very much. Next week, sorry, I think our next seminar will be on Thursday. We are going to look at glaucoma, okay, which is the second leading cause of blindness, okay.